controversial, right? So let's start with this one. I'll read and you'll type as usual. So, my volume on. 15-month-old has been breastfed since birth and eats finger foods and occasionally some cereal. Mother adheres to a vegan diet and plans the same for her child. A complete blood count documents anemia. The following, the most likely cause of this infant's anemia is a deficiency of. Right, good. That's it. So it's B12, it's the vegan, it's the breastfeeding, plus the fact that there isn't a whole lot of protein and other stuff in there. And remember the other way that these MCQs come sometimes that is a Q is the Rastafarian, but it's the same thing, right? Okay, let's do 2. 15-year-old boy comes to your office for a health supervision visit and he expresses concern. He's only 5'2" and he's not competitive in his track and field. And on physical examination, he's healthy, weighs 96 pounds, testes are 7 mils in volume, slight pubertal phallic enlargement, sexual maturity rating of 3 pubic hair, small amount of subareolar breast tissue. And his last health supervision visit was 2 years ago, where he did not have pubic hair at the last visit, and his testes were described as pre-pubertal in size. So of the following, the most likely cause of his short stature is. Right? And everybody was not sure, start to eliminate. Klinefelter's is tall, rubbish. Prolactin normal. He has subareolar breast tissue, that's normal. A and D are ridiculous. Does exercise really cause you birthday? No. So, right. So a lot of these questions, the mental constitution of delayed puberty, they really buried you with information here that wasn't necessary. If you kind of look down, the other answers were a bit silly. So A is the answer. So even if it looks, sometimes even if it looks like it can be confusing, if you look down at the options, this was one that I think was easy to eliminate, right? So this is constitutional delay. And sometimes these boys, when they do hit puberty, they end up taller, right? Right, let me make sure you can see this. So 7-year-old presents to your clinic with a 2 to 3 day history of a non-productive cough and malaise. Temperatures 38.3, and on physical examination, there are crackles in the lungs. The chest x-ray is shown. And I'll give you a little chance to see it. Okay. Yeah, a question similar to this before. So look and see how the trends here. Of the following, the most appropriate antimicrobial agent to treat this girl's infection is. Yes, B. Okay, so this is B. So this is azithromycin here. We're going back up. We're looking at the child is greater than 4. So you're looking at mycoplasma. The crackles, yes, but this chest X-ray, remember I told you mycoplasma is weird in that it can give you a lobar consolidation pattern. It can give you a reticular nodular pattern. But this kind of diffuse perihilar, that tends to be, the one that they will bring here. Even I'm wondering if with a little bit of this blunting here, there may be something in this lingular area, but still, the story and the pattern with the perihilar looks most like mycoplasma. So that's what you're going with. Azithromycin, clarithromycin, erythromycin, whichever one of those is. Right. Speaking the mother of a child who attends a school, which was left out, where a student was diagnosed with meningococcal disease 24 hours ago. Her child does not have any classes with the index patient, and except for passing her in the hall during lunch 3 days ago, has no contact with the index. The mother is frantic because the school sent home a notice asking parents to take their children for a doctor for advice if needed. Of the following, the most appropriate advice for this parent is that her child. Okay. Well, I only seen a few answers, but it is A, so you weren't supposed to fall for it. Does not require prophylaxis. It is intimate contact, so it's household people in the same bedroom and that kind of thing. So it is intimate contacts. Um, but really, to see if she's developing to be evaluated, I wouldn't go there. She really doesn't have any risk passing in any hole 3 days ago. She does not need an nasopharyngeal culture, and she does not require prophylaxis, right? So it was between A and B. If you would fall for, let's see her to see if she needs help. But if you look at the contact, you're not even saying, she sat next to her, you weren't even anywhere close, right? And it's usually quite close contact. Right, so A is the answer there. 60, seeing something similar to the do. A 15-year-old presents to the emergency department 30 minutes after eating at a seafood restaurant. He states that 10 minutes into his meal, he became itchy. He has a history of shellfish food allergy, but he ordered steak and denies eating any crab, lobster, or fish. On physical examination, the patient appears to have labored breathing, a rash as shown below. His respiratory rate is 22 breaths per minute, pulse oxygen 92% in room air. Of the following, the most immediate appropriate. Eek. Why can't I see? Right. Okay. So everybody got that. Um, yeah. I mean, what they right. So hives in the periphery doesn't really mean that you're getting anything in the airway, but as you go on in the question, the labored breathing and the SpO2 tells you that there is airway involvement, even though the rest of the vignette doesn't describe it. Yes, you would go with the intramuscular. Right. 3-year-old has a history of recurrent otitis media with effusion in infancy and is brought to clinic. His mother is afraid that he has a hearing loss because he doesn't talk as much as his brother did at the same age. He speaks in 3-word sentences and you can understand fewer than 50% of his words. Results of his physical examination, including his ears, are normal. Of the following, the most appropriate statement regarding his condition is that A, B, C, or D. The most appropriate statement. Okay. Yes. Mm. Okay, so a lot of you think D. The answer in this is A. So even a mild hearing loss that I don't remember which bank I got this from, can affect his performance later. Okay. Right. So was the obvious rubbish. And C, a hearing test with a normal examination adds no value. That was also bad because you can look normal and have a hearing problem. So B and C you eliminated. So it was between A and D. I know why D is a little weird. How good do you think D would be in a 3-year-old? Yeah, that's exactly what it is, right? So it's A and B, but a 3-year-old telling you which side is louder, that ain't happening, right? And that's why the A was a better answer than D. You could have eliminated B and C a lot. Remember, remember eliminating is one of your main is one of your main things. All right, so A and B. Let's go. Right. So a 17-year-old girl complains of clumsiness over the past 3 days. She has had moderate headaches for 1 month, neck discomfort for 3 days. Physical examination reveals a right-sided dysmetria, an up and a left upper and lower extremity numbness, the pinprick, and weakness graded as 4/5. Remainder of examination results are normal. Of the following, the most appropriate evaluation to establish a diagnosis would be. Yes. Yeah, you all are correct. It would be A. What are we thinking of here? Yeah. So you're thinking of a tumor, posterior fossa tumor, something like yeah, astrocyte tumor, or yeah, that's what I'm thinking of, a cerebellar tumor or something like that in that region. That's what this makes me think of. Urine toxicology would not describe that. Lumbar puncture would be no, right? There's nothing else that would really give you a good answer there, right? So you're looking for a space occupying lesion, probably cerebella, as they said, dysmetria. Okay. So evaluating a 4-week-old male with projectile vomiting after feeding for the past week. After reviewing the patient's electrolytes, you obtain the ECG below. Now, I feel you don't even have to watch the ECG, right? Let's go. Right? I'm going to show you the question and then scroll back. Or is it just that it's too big? Of the following, the most likely electrolyte abnormality suggested by the ECG is. Correct. Okay, so right. So what is the condition? Type for me. Oops. What did I do? Right, she has a pyloric stenosis. And what are the classical findings?
Things that I've studied based off of medical equipment, but it's pretty cool. So maintain and repair. Yeah.
Hold on. Pyloric stenosis. And then what? Right, that's exactly what I want you to say, right? Hypokalemic, hypochloremic, metabolic acidosis. You need to know that like a little poem, right? Because it comes over and over. And what are you seeing on this ECG? Hypokalemia. So even if you didn't look at ECG, what are you seeing on the ECG? A lack of flattened T waves, right? That's it. Okay. So, right. So that's a pie. Remember, no, I think I'll come across another question. All right. 16-year-old is being seen in your clinic because of headaches for the past month that awakens her at night. At her last visit 2 years ago, she was 5'2", 105 pounds. SMR is 4 breasts and 4 pubic hair. She still hasn't reached menarche. On examination at this visit, 2 years now, she's still 5'2". She weighs just 5 pounds more, and she still hasn't begun menstruating. On evaluation, you note bitemporal visual field defects because you're brilliant, perhaps worse on the left. In addition to an MRI and an ophthalmologic evaluation, what would you most likely find on the lab? That's diagnostically revealing. Right. Right. So they're giving you a scenario. This is not constitutional. She has a tumor. They're telling you there are bitemporal visual defects. So you know there's something affecting the optic chiasma. This is something that's affecting growth hormone and prolactin. Okay. A 2-year-old boy presents with a history of vomiting and diarrhea for several days. He has lethargy, poor oral intake, tachycardia, dry mucous membranes, and poor skin. His capillary fill is 3 seconds. Of the following, the best next step in fluid management is to right. Okay, our recess bolus, it's always the same. It is supposed to be normal saline, but they're putting here normal saline at 20 mils per kg. Yeah. Right. There are some circumstances where you give it in 10 aliquots, like in hemorrhage, where you don't want to dislodge in an accident, and there are some of the circumstances you need to remember that they divide it into 10, but a recess bolus is generally 20. Whoops. I didn't want you to see the bottom. That was an explanation. Okay, so a 16-year-old girl presents with complaints of a right upper quadrant pain and right shoulder pain, nausea. She's afebrile. She has begun taking the oral contraceptive pill for, I can't read that, 6 months. And the results of an ultrasonography of a gallbladder performed after an emergency department visit 2 days ago are normal. Of the following, the most appropriate next step in evaluation of this patient is right. Okay, so I'm seeing everybody going with D. So, right, CT A and B were stupid. So we could have thrown that out. And the question here was whether we were going to, depending on the history, whether we were going to C or D. Now, this is what they're going for. I'm thinking, I added this on. They put the answer as actually C. Because they, in a way, if you look up, they already told you that her ultrasound was normal. They wasn't going to ultrasound just her gallbladder, right? They would have done her ultrasound. What of her? Yeah, because they had done this already, this may not have been the next best answer. And I could see why they were going for pelvic. But I thought it was strange that they did right upper quadrant and right shoulder, but they were talking about referred pain. What syndrome you call it? I didn't think this is what I was going with. I don't know that one. Sorry. This is what I was calling it. This is what I thought it was. Curse sign. Tell us what that one is. But I didn't do gynae for a long time. But I was assuming from listening to it that this was a ruptured ovarian cyst that gave you curse sign and referred pain to the tip of the shoulder. It would have been much easier if they put right lower quadrant pain. That is what I would have written for this. And referred pain to the, and usually these things go to the left shoulder. So I find the whole thing, I would have written this a little differently to make it clearer. Oh, okay. Hepatic adhesions from PID. All right. Yeah, but I think it was between C and D, and I think that maybe because they already did an ultrasound, C might have been a better answer. I thought they were going with curves right away, but there was some stuff in this that I would have written a little bit different. But the answer here in the old question was pelvic exam. Well, I'm just saying, I am thinking it is a ruptured ovarian cyst. It's possible that y'all, because this is probably more gynae, maybe you could ask them. That's what I'm thinking that it is. That they're talking about curves, even though that's usually left. I'm thinking that that's what it is. Right, and remember that curves, just to be off the thing, remember that curves was originally due to a ruptured spleen, but anything in the peritoneum can. Okay, so infant is delivered by cesarean at 34 weeks because of preterm labor. No history of ruptured membranes or maternal fever. No abnormalities in fetal heart rate monitoring. And the infant requires assisted ventilation with a bag mask device, 100% oxygen in the delivery room. His APGAR scores are 3 and 7, 1 and 5 minutes respectively. He's admitted to the newborn nursery, but he's transferred to the NICU within an hour for respiratory distress manifested by tachypnea and grunting. His ABG results on admission to NICU are pH 7.0, PCO2 70, PO2 50, and base deficit of 10. Of the following, the most common cause for this infant respiratory distress is. Now, again, full of thinking, but then some of those options are so stupid that it'll get you there. So everybody's going A. Okay. Yes, Selena. The answer here is D, and I think I would have gotten there. You really get buried in nonsense here, but let's go through how you're thinking this through. One of the nasty things about this is the gas, but all right, let's just go through this. They actually do like this, going through respiratory distress. And you are now going to be looking for cues of babies. You're looking for cues that tell you, is this TTN, transient tachypnea of a newborn? Is this RDS? This is the normal answers, right? Not all of this craziness. Is this meconium aspiration? Is this pneumonia? Or is this a zebra? This is how you should be thinking, right? So you had respiratory distress from birth. The cue to TTN is that it tends to happen. All right, so it tends to be a C-section baby who hasn't had chance to kind of squeeze out all the fluid, and they tend to develop the tachypnea. Sometimes it takes a little while to develop the tachypnea, so they may not be born with it. And the chest X-ray is quite classical. It gives you this real liquidy, streaky, perihilar infiltrates. That's a lot of fluid. And then they just get better. So within, it tends to develop, peak around 2 years, and then around 2 days, they're fine. That's a good question. I'm going back to Sharika and what she's saying. I think they are doing a pelvic exam in that you are looking to sort of try to localize where the tender spot is for. I didn't think it was a particularly good question. Maybe you could ask gynae, but I think it could only be those two, and you had already done an ultrasound, and that's why I think they're going for pelvic in that. This was probably, as soon as I read it, I thought it was ovarian. It's which one of these probably did the ovarian. You could probably ask. I don't think the question clear, but they did an ultrasound 2 days before. That's probably why I would not have done that again. All right. And I mean, and if they had done an ultrasound of the pelvis, then they would have picked it up, and that would have been a better answer than a pelvic examination, pelvic ultrasound. Okay. Yeah, but going back to here, say your thought processes. You've developed this respiratory distress, this TTN, RDS, meconium aspiration, pneumonia. But there are lots of things in your vignette that will cue you. So it is a cesarean section, but this is not like a TTN, because this degree of respiratory acidosis, you're not going to get this, right? And so not like a TTN story. Respiratory distress, you're getting usually more prem than 34 weeker, and you are getting a baby generally right away. You would not have had this delay where when they were so good, you send them to the nursery, and then an hour later you had to transfer them to NICU. That made it not likely to be an RDS. Meconium aspiration, they really didn't give you anything. You would have been born with it right away, and they really didn't give you anything like they would normally do and tell you that there was meconium in fluid. They didn't say anything. So that's kind of out of the way. But remember, again, aspiration of amniotic fluid can happen, even if it's not meconium, but the respiratory distress is usually immediately after delivery. Pneumonia, they went out of their way to tell you that this is not a pneumonia, because they told you no fever, and they told you no something else. There were two things. No history of ruptured membranes, right? Other thing against the aspiration was that usually these aspirations are triggered by hypoxia, fetal distress. And they went out of their way to tell you that the fetal heart rate monitoring was normal. So you're going down your way, and you're at zebras now. Look at these options here. Hemothorax sort of comes totally out of the blue here. That you did develop the hemothorax. That's a weird one. Pneumopericardium, they would have given you muffled heart sounds. They would have given you something else. It's weird. But what they really, I don't love the question again, but what they're going with here as well is that this blood gas of pneumothorax is sometimes telling. Still not 100%. But the blood gas in the pneumothorax can sometimes give you this. So you're getting this high CO2 hypoxia, and you're getting this. So you're getting this a respiratory acidosis here, and that's what you get sometimes in pneumothorax. Not a lovely question, but if you would have been in your little unit, you realize how easily they actually rupture their lung. It happens a lot. It's not so much of a zebra as you think. So the actual respiratory acidosis, you're required to know these norms, even though they would give it to you in the other sheet. It's nice for you to know what it is and not have to refer to the sheet. So you can see in this case that it was acidotic hypoxic, and the PCO2 was elevated. They didn't get the bicarb. So normally you look at the PCO2 for the respiratory part, and you look for the bicarb to tell you there's a metabolic component. But you can see this base says here, they give you a base of 10. And also they like to describe x-rays for you. So just putting off of the question, if they were to give you respiratory distress, if they were describing things like broncholas appearance, you're looking at RDS, you're looking at the prem, right away RDS. If they were to give you fluid in the fissures, or you were to see fluid in the fissures and a very highly streaking, you would think of TTN. And for the meconium aspiration, you're looking at peptide infiltrate with an increase in the AP diet and flattening of the diaphragm. Right? So these are the classic things that come up in the vignette, and this is usually what your neonatal respiratory distress questions are. This is a weird question. Okay. So you're evaluating a 15-year-old in your office boy in your office, and he tells you that he experienced chest pain sometimes while at home or at school. He describes it as sharp left chest exacerbated by breaths, and resolves spontaneously. He doesn't have palpitations or lightheadedness his 54-year-old father and grandfather both have had hypertension and myocardial infarction. At this point, he has no pain and the results of his physical examination are normal. Of the following, the most appropriate approach for this patient at this time is. Nobody else? Right, okay, that's all right. Yes, y'all have right. So this is just reassurance. He doesn't have anything cardiac. This is more likely to be his chest wall. It's common. It osteochondritis, something clunky, it's exacerbated by breathing, and he may be a little anxious about it because his father and grandfather had something really that component. You make sure that when you tell them to follow this is not something. Consistency. Right. So the Tanzania voice circle here presents the evaluation with members laxity and point location. The family history is notable, but his father and his sister having some concerns, and an aunt that died, with the fits. I'll go to the question and come back. Based on the genogram, you can kind of see it. It does say here that grandfather had it, father to aunts, and some other things. Based on the genogram, most like paternal inheritance, this is what it is. Okay, yes, that's it. So you see male and female, you see about, you see here 50%, you see here 50%, and you see so dominant. Just another thing, this like the definition is so dominant, we make a slack. Good, that one, we're supposed to figure out. Anything else? What do you think about? Right, definitely. So the first thing I thought you would think about was maths, and then I was stretched. So that actually that like syndrome, think about even those, because that's sort of anxiety. Inheritance is even learning different types of maths. So some are some are different, but really good. That's very good. So this is even done with someone. Okay, you can treat it 2-year-old, but you common diagnosis by 5 days. Of the following, like complication of the disease would be. Yes, this is hearing impairment. Somewhere in my mind, the hearing impairment is worse than the muscular influenza. That's the one that triggers, but I think it is still hearing impairment. Can somebody check me on that? I think the hearing impairment part is with muscular meningitis. So somebody can look to me. But of these answers, the most likely complication of meningitis more than all of these things here in a child would be hearing. somebody look for me, Google which one of your pre-meningitis. So basically, when we think of meningitis, it's like meningococcal, H flu, or pneumococcal. Which one is the most related to hearing impairment? I'm thinking it's the most. I'm not sure. Is it that? Anybody see that? Okay, you can check another time. Let's move on to number 15. 12-year-old girl presents the office for the first time with swollen, painful erythematous right knee joint. Tells you that her left knee looked and felt and looked similar yesterday, but is now normal. She's also easily fatigued and has had fever. On examination, she had a temperature, her heart rate is 125, respiratory rate is 24, blood pressure 120 over 78. Okay, pneumococcus is the most associated. All right. The lungs are clear, and on auscultation, there's a 3/6 holosystolic pneumonia at the cardiac apex with radiation to the axilla. Right, so you have a good idea of what this is. And now it says, of the following, the best plan of management for this patient's joint swelling includes. Right, good. Good, Saif. It's anti-inflammatory therapy with aspirin. You're treating what? Yes, rheumatic. There we are. Rheumatic fever. Okay, and this was a total Q. You just have to hear. This is a MR, right? So, okay. A 4-week-old boy has been vomiting all of his feeds for the last 2 days. His mother reports decreased urine output, but no fever. On physical examination, he's alert, he appears hungry, moderately dehydrated. The abdominal examination reveals a small mass in the epigastrium. When he's offered a bottle, he takes it vigorously and then vomits it forcefully. You order lab tests of the following. The most likely abnormality is, here we go again. Right, hypochloremic metabolic alkalosis. So these vignettes are pretty classic. You will get anything between sometimes up to 12 weeks. Risk factors we might throw in there, cesarean section, firstborn males, we like to put them to be males. We may use the word projectile or we may say forceful, so it wouldn't cue you. They're usually hungry. Remember, they have this olive-shaped mass, so if you see that word olive-shaped mass, it should cue you as well. They also talk about, but I have never seen this in my life, even though I've seen many pies, peristaltic waves that move across, right? And we need to remember this, obviously, this hypochloremic metabolic alkalosis, because it'll come again. In the radiology, there are signs that they love. So we talk about the target sign, where due to the hypertrophy, the hypoechoic muscle, you get a target sign in the ultrasound. They have the string sign in the barium and a double track sign in the barium. They have a whole lot of signs in there. I can see the surgery people putting in something like this for you, not us. Okay, 17. 10-year-old child had cognitive testing that showed full-scale intellectual quotient of 105. On achievement testing, he performed at the 3rd percentile in reading and at the 50th percentile in math. Of the following, these findings most likely represent what? Right. Okay. So, yeah, not a vignette of an A. B is not a good answer. It was between C and D. The fact that he wasn't reading well might make you might give you pause, but yeah, might make you wonder about his vision, but his specific learning disability was the answer here, C. All right. There's one of those, you gotta know it. You're seeing a 14-year-old boy in the office complaining of fever, facial pain, and cough at night. His mother states he has problems with sinus for the past few months, and he has required repeated antimicrobial therapy during this period. Physical examination reveals a temperature of 38.3, yellow-green nasal discharge, and tenderness to palpation of the maxillary and frontal sinuses. Of the following, the most likely pathogen associated with chronic sinusitis is. Now, of course, you didn't even have to read the vignette. You could have gone straight to the question. Because the question itself goes and gives you the diagnosis. Yeah. So, most common pathogen in chronic sinusitis. Everybody saying C? Okay, you all Google that because I have, as far as I remember, A and C are acute and chronic is B, and I have B here. Google it, tell me what you get. Chronic sinusitis. Because remember, sometimes these questions are, when I pull questions and they were 2 years old. Yeah, I have B here. Just Google it and check. Most common pathogen with chronic sinusitis. Somebody say they looked. Because I didn't get a chance to look through anything. Yes, Staph aureus. Okay, right. So that's one of the remember. So I think Staph aureus for chronic, but Moraxella and strep pneumonia are acute. So just remember that. And remember, now that we're unified, we like these kind of multidisciplinary questions. Okay, so you're seeing a 2-month-old male with trisomy 21 for health supervision visit. And the boy's mother expresses concern that he's been having noisy breathing during the past 2 to 3 weeks. No choking or feeding difficulty, but according to the mother, the noise which occurs on breathing in is louder when the infant is flat and when he's crying. There's no symptoms, no rhinorrhea, cough, or upper respiratory tract infection symptoms. Infant was born to uneventful vaginal delivery, and on examination, yes, physical appearances of trisomy 21, resting, he's comfortable, he's appropriate for age, but you're hearing an audible noise during inspiration. The most likely explanation for his respiratory symptoms. Yay, you're just, yeah. So laryngomalacia, yeah, the trichomalacia and vocal cord paralysis, not a good answer. This is a really rare cause of that, and it wouldn't give him. This is a classic vignette. When they tell you this thing that it's louder when he's lying flat and crying, is pretty classic for laryngomalacia, and they outgrow it thankfully. It's a nothing much. Just gets a little floppy when they're lying down, and then when they're up, it's fine. So fun time classic for you. Okay. 4-year-old boy presents for health supervision visit, and in the course of his visit, his mother discloses that ever since birth of his 2-month-old sister, the boy has resumed bedwetting, which had ceased to be a regular occurrence. He's dry during the day. He has no stool incontinence. His past medical history reveals that the child has never been hospitalized, had negative urine cultures at 9 months associated with a fever, and was toilet trained completely at 3, with only episodic bedwetting once a month. Physical examination reveals a happy, playful child. Growth and development is normal. He is circumcised. They added that in for you. A normal scrotal examination, meaning that he has no hypospadias or anything like that. And urinalysis specimen obtained shows normal results. Of the following, the next best step in management of this boy is 2. Right, agree. So, yeah, I think we came across some of this before. Sometimes when something happens and you're always seeing the vignette, new school, new baby, a milestone that they achieved, they may go back a little bit, but saying he's happy and they're really telling you he's got no UTI in every way possible, right? So you can just reassure and check this again, you know? Okay, oh, I thought this was clearer. 6-month-old girl is seen in emergency department with concerns about irritability. The child wants to take a bottle, but she fatigues quickly thereafter. On physical examination, there's no fever. Her respiratory rate is 50 breaths per minute, heart rate of 250 beats per minute, and blood pressure 80 over 50. O2 sat is 98% in air. Her lungs are clear. Her rapid pulse is palpable in all extremities, and she has a capillary refill time of 2 seconds. ECG is shown below. Right, I'll scroll back up. So, of the following, the best management plan for this infant is. Okay, so what does she have? 250. Yes, she has an SVT. SVT, common enough. You see in these narrow QRS complex tachycardia, more than 220, it's 250, right? But it's an SVT, but there's a trick in this. There's a trick in the management plan. So normally, you don't, I think somebody checked me, under 10 or under 12, you don't use verapamil, right? And it's not your first drug of choice. Your first drug of choice is adenosine. If the child is stable, you do vagal maneuvers first. Basically, in real life, you do vagal maneuvers while you ask somebody to pull up your adenosine in case they, yeah? So vagal maneuvers if stable. And then you pull up the adenosine. So you definitely, the shocking is unstable, right? They didn't really tell you that she was unstable. Her Capri-Fill is still 2, right? So she's okay. Capri-Fill still 2, fairly stable. B is out. Verapamil is out in children, but I can't remember the age. Somebody checked me, 10, 12, something like that. But, you know, in all honesty, I look up these things in the situation. So it's vagal maneuvers first. So you never do an eyeball massage in a child, or I don't think anybody. The vagal maneuver I would go for is the ice pack or the dive, where you take them and you push their whole head down into water, which we've done that already. But they don't have that. And carotid massage is now not recommended in children. And that's the trick. So even though you go vagal first, they haven't given you a good vagal here. Right? So somebody, 2 things for me. Somebody check for me what age you can use verapamil from, and even so, it's not first line, so it doesn't contribute to this answer. And the other thing to check for me is, yeah, I think carotid massage is not done in children. Just double check that. It's the ice maneuver I would have done, the diving ice one. Yeah, okay, right. So this is very tricky. You would have gone with a vagal, but not this vagal. This is an adult question. If this was an adult, A would be the answer, but it ain't. Right, and verapamil, no carotid, no eyeball. That's right. And verapamil from what age? 12? I can't remember. I don't do these things, see? Because I wouldn't even get down to here. Verapamil is not used in under 10 or 12. So, under 2? Okay. I thought it was a little, I thought it was more than that. But all right. Anyhow you take it, that's not your next step. Verapamil is further down the line after you fail adenosine. 2 to 12, it can be used. Okay. Yeah, so the answer is C, correct. You're going for adenosine. Yeah, you're going for adenosine just because they did not give you a good vagal option. Yeah. Because they said of the following. So there we are. All right, 23. 3-month-old boy, previously healthy, is brought to the emergency department with a 3-day history of rhinorrhea, mild cough, and wheezing. He's been afebrile. He's had some difficulty feeding. His pulse ox is 90 on room air. Respiratory rate of 60 breaths per minute. Heart rate 130. Chest examination reveals mild subcostal retractions, scattered wheezing, and coarse crackles bilaterally. The rest of his examination is normal. So you have it good in your head what this is. Of the following, the pathogen most likely responsible for his symptoms is yes, of course, right? This is good old bronchiolitis, right? So it's RSV. Right, 15. 24. A 15-year-old previously healthy girl had an episode of syncope in gym class. She awoke after a minute and was taken to the emergency department, where her physical examination findings were now normal. Results of ECG are shown. This real wicked, but I think you can do this by elimination. But anybody who knows this, power to you. I think I did this one by elimination. Okay, so all right, so let me tell you how I went through this. WPW, the ECG doesn't show you. Yeah, okay, Rashida, you got it. The ECG doesn't show you WPW that well. Now, it's hard to call that, but if we wanted you to pick up that delta wave, we would have made that much more obvious. You see this bit here would be slanting here, and you see that delta wave. So you are looking for which of these syndromes gives you syncope, right? So WPW here, you're looking for this delta wave, even though it's not great, you're not seeing it great. We would have showed you if you wanted to see this. Brugada syndrome. So you are required to know. I mean, there's wickedness. They probably tell you this in I mean, the peds cardiologists would talk about it, and the adult people, but it might be a little more common in the adults. So you're kind of trying to go through your cardiovascular cases, the causes of syncope in your head, and what they would ask you in an ECG. And what you might be looking for is WPW, long QT. Brugada gives you a particular thing with the ECG, and some of these other things you can't pick up, right? The structural things. But Brugada gives you a particular story that they're not giving you here. It tends to be the sudden death. They tend to be a little later in life. They tend to have something in the family. And they give you these pseudo right bundle blocks and this what they call coved ST segment elevation, which you're not seeing. So that's Brugada. But that's weirdness. The story isn't like Brugada. So if you didn't know what it was, I would say, I'm not really seeing delta waves. Nope. The story not like Brugada. And if you knew about the ST elevation, I'm not seeing that there. And maybe the sinus rhythm with premature contractions probably not going to cause syncope. They're not going to cause this child to pass out. So by elimination, prolonged QT. So now I go back and look at these QTs, how far they are, right? And I'm not good at knowing, yes, it's more than half. It is. And it's one of my things. Anything like this that requires a whole lot of counting out, I wouldn't do. But I still think that you should have spotted this or been able to eliminate the others. It's not so bad. And it did come in a question. So here we go, prolonged QT. Right. So you're asked to see a 14-year-old girl who developed pubic hair at 11. breast buds at 12. That looks like a strange sequence, but has not reached menarche. She's a gymnast. She practices 2 hours a day, and her breast tissue SMR is 2, and pubic hair SMR is 4. She's 5, is that 5'7"? No, 57 inches tall. I don't know what that is. And she weighs 86 pounds, so she's smallie. Okay, so the results of her lab tests are, so you're starting to wonder, she's not developing, right. So results of her lab tests are, her luteinizing hormone is 18, right? A normal adult female, they give you the ranges here. Her FSH is 40. They give you the normal here, 1 to 30, so it's a little bit high. And they're asking you now, of the following, the most likely cause of her primary amenorrhea is. Eek. What y'all think? Just so excessive exercise and not eating can delay your puberty, but autoimmune, yeah, that's a hard question. The answer they have here is D. Yeah, the answer they put here is D. I didn't really see this question before. I'm not sure other than the cues in the, yeah, I think they would have, so she's short, she's not developing, and her FSH is high. So there's something ovarian that's not happening. So Turner syndrome gets that ovarian streak where they don't get, so that's why this FSH is high. So it's ovarian. So it's some sort of ovarian thing. It's not just these two because the FSH is high. So you're between A and D. But autoimmune ovarian failure, you know what that is. If they had said ovarian failure, autoimmune, let me think. I don't even know. I don't know. Turner's might have been my answer. I guess. Because the FSH was high, I would have said it's between ovarian failure or syndrome. And if I was going to give you something syndrome, I would have put something nice in the vignette like, oh, a shield chest or a neck or something to cue you. So that's a little bit wicked. But I'm not quite sure what autoimmune ovarian failure is. The answer here is D. So somebody could Google that for me. Is there really any autoimmune cause of ovarian failure like that? Because I can't even think of that. So it is ovarian failure because that's what Turners have. They have this ovarian streak. But I don't particularly even know why they would. Let's see. Autoimmune ovarian damage. Okay. Not a particular, doesn't sound like anything that common, I guess. And that's probably what it is. So, all right, so they didn't make it up. It can happen, but I don't think it's that common. Turner syndrome would have been a better answer, given that they were short and not developing, and yeah, breast should be before pubes. That's a yeah. Oh, so you mean that was a cue to the fact that I thought the question was wrong, but yeah, that might have been a cue to the fact that she was developing out of sequence because it's supposed to be boobs before pubes. Okay, so Turner's is the answer that's in this. Let's go. 14-month-old is brought to emergency department with a 12-hour history of fever and rash. The mother became frightened when it was difficult to arouse the girl after her nap. Findings on a physical examination included temperature of 40, heart rate 164, respiratory rate of 42, blood pressure of 75 over 45. They have petechiae and purpura on chest, arms, and legs. God, I love this. Which of the following is the most appropriate therapy? Yeah, you're not spending too much time on that. A. So if you look in some, right, so I've seen variations of this question. So one variation, obviously, several variations have a picture in it. One variation will tell you that you're in a health center setting where you may not have ceftriaxone and try to push you to give penicillin, which you can't do. And when you look at North American protocols, because of their actual susceptibility, some of the North American MCQs will go straight for bank, but we will not go for bank. But ceftriaxone will be the answer here. All right. So you diagnose tinea capitis in a 7-year-old girl. She's otherwise healthy, and she has no known allergies to medication, and you prescribe her oral griseofulvin. Of the following, the most appropriate to prescribe the drug, it is most appropriate to prescribe the drug A, B, C, or D. What's the diagnosis? The previous one, meningococcal septicemia. Same thing, meningococemia. Right? So just remembering, depending on where you are, this answer might be different. Primary health center, hospital, this is North America. Tinea capitis, you're prescribing the drug. What do you do first when you prescribe this drug? Now, griseofulvin, you know, can give you jaundice. Right. Okay. So even though griseofulvin, now I think I threw you off by saying that. So that is what we worry about. So whenever we give griseofulvin for tinea capitis, this is what I do. I'm giving you this for 4 to 6 weeks. If you see anything yellow, looking yellow, you stop and come back, and I will see you back in a month. I would not necessarily do the LFTs. Okay? That's just what we do. So the answer for number 26 is ceftriaxone A. 27, you are going to, you're actually, what you're worried about is jaundice, but you are going to do a follow-up, but you're going to give them the follow-up with guidance that if they see jaundice, they have to stop and come back. Okay, so the answer for this one is C. All right. A 5-month-old female presents with a 1-day history of fever, emesis, and multiple episodes of green diarrhea, which streaks of blood. Her mother states that she's less active and sleepier and has no interest in feeding. Physical examination reveals a listless infant with a sunken anterior fontanelle, dry mucous membranes, decreased skin turgor, and skin irritation on the diet. Of the following, look at her age. Of the following, the most likely cause of this patient's gastroenteritis is 27 is C. You start it and you give them guidance and you look at them back again. You don't have to stick them because that's sticking a lot of, yeah. All right, so 5-month-old with diarrhea and dehydration. Very common. They all get it if they don't go and get the vaccine. Where are we? 28. Yes, 28 is C. 28 is C. Rotavirus is pretty common. Remember, in Trinidad, I don't know about all the other islands, you still have to pay for Rotarix. So if you were to get a scenario in your history with gastroenteritis, don't just ask, you brought your immunization card, you're up to date, that's not good enough to me. You need to ask if you went anywhere and paid for your Rotarix. It makes a huge difference because you really, I mean, children, a lot of children die from rotavirus every year. It's quite common, and they get seriously dehydrated, generally greenish diarrhea, may or may not get the streaks of blood in it. The rotavirus is just the most common one there. The other one that gives you blood is Salmonella, Shigella, and the enterohemorrhagic E. coli, right? That's what you're looking at. That's what you're thinking of when you see blood. But in childhood, it's going to be rotavirus. 2-year-old boy is brought to the emergency department with a high fever for 6 days and irritability. His clinical findings are shown below. Is there another one? All right. Face, hands, eye, and mouth. Right? Of the following, the most likely diagnosis is. Some of these were all, and I had to eliminate the E. Right. Okay, good. Kawasaki for sure. It's not scarlet fever. Wouldn't have, scarlet fever, not the same. Even though you can still get that dryness in your mouth. Okay, so that's B. 10. 30. A 10-year-old girl presents the emergency department with the urine showed below. There's no dysuria, frequency, abdominal or flank pain. Her vital signs are as follows. She has she doesn't really have much of a temperature. Her blood pressure is elevated, heart rate 84, respiratory rate 20. On physical examination, she has moderate periorbital edema, but there are no other abnormalities, and her urinalysis reveals moderate blood and 3+ protein. Her C3 is low and her C4 is normal. Of the following, the most likely cause of this girl's hematuria is. We love this question, don't we? Yeah, I might just go from the picture and scroll down quickly. Right, see the blood pressure and just scroll down. That is one of those questions that I'll just do on the fly. Okay, 31. 7-year-old boy with sickle cell disease is referred to the pediatric emergency department with a 5-day history of fever, rhinorrhea, headache, and worsening fatigue. Physical examination reveals a tired appearing pale boy with a temperature of 38.6, heart rate of 150, and very pale conjunctiva and mucous membranes. He has a faint diffuse erythematous lacy rash that is prominent on his cheeks and trunk. Wow. Lab tests are as follows. You don't even need to read the rest. Oh my God. So he's got suppression of all his lines. Hemoglobin, retic count of the following most likely is parvovirus. So this is 5th, parvovirus. Yeah, giving you what we just talked about, a plastic crisis in a city. Right, 32. When should a child be assessed for possible attention disorder as a primary condition? So which of the following is the most appropriate? So it was said, attention. Right. A 3-year-old not paying attention in class, kind of normal, he's 3. Started speaking 6 months ago. We do give children up to 3 to speak in sentences if they're understanding. Even though they generally should be able to put in 3-word sentences, we kind of give them up to 3. So ADHD, not really. 5-year-old doesn't look at you, and this time they're going autism spectrum. 6-year-old reversing B&D, well, we know what that is, more dyslexia, sounding out some words. So a 7-year-old speaks well, reads fluently, but he won't complete his work and he forgets to hand in his assignments. Yeah. Seem to like that too. 33. A 14-year-old female comes into clinic for medical certificate once a week for multiple complaints with chest pain and abdominal pain. The complaints are non-specific. Her physical examination is normal. She's quiet with poor eye contact. States that the pain is worse on school days. Her mother is also concerned that her daughter is being bullied but won't talk to her. Her mother is worried that her complaints represent an undiagnosed medical condition. The next best step in management is, right, the adolescent people love these things. Yeah, she needs counseling. Somebody needs to talk to her and figure out what is going on in school. There's something going on. Yeah, so the answer here is B. 84. A 2-year-old, otherwise well boy, presents the outpatient clinic with a 6-month history of 3 to 4 loose bowel motions a day. His mother was particularly concerned as she can see particles of undigested food in the stool. Weight and height normal. Which of the following is the most likely diagnosis? Yes, and that's how I like it. From the time I see undigested food, scan, undigested food, straight down to D. Toddler's diarrhea. We call that peas and carrots diarrhea, peas and carrots stool in a toddler. Normal. Right. A 3-year-old previously well boy presents to the Paeds emergency department with a first seizure lasting 15 minutes. Seizure started with twitching of the right hand, lasted for minutes, and then it became generalized, involving his whole body. He was unresponsive at that time. At the PD, his temperature was 40. Of the following, the most likely type of seizure is? Yes. So we're looking at more than 15 minutes, but the fact that it started on the right hand means that it was lateralizing, and that's what makes it a complex fever. Okay. Right. I told you all about this, but y'all didn't actually see this. So a 3-day-old exclusively breastfed baby was noted to be passing salmon color discoloration on his diapers for 1 day. Hey, y'all answering. Baby is well. Mother complained that she had developed what? Sore nipples since commencing the breastfeeding. Of the following, the most appropriate action is to. Right, so there's 2 things going on here. One is so there's 2 possibilities, but the answer is still the same. One is that it's just plain salmon color tends to cue to the uric acid, which has nothing to do with the sore nipples. And the other one is ingested blood, which they do. Anybody knows the name of that test that you can do to see if you swallowed blood? Because I think I have a name in my head and I'm corrupting it. What is it called? So it can be any of those 2 things with the sore nipples and the salmon color and this, but the important thing is the answer is A. What's the name of the test that you can do on the stool that would indicate it swallowed blood? More stool. I think it's either guaic. Yeah, it's either guaic acid. Is there why am I thinking of a ept? Okay. There's a name of a test, but it's along that same line. Fecal occult test. There's another name for something that's like that they get in swallowed blood. All right. A 5-year-old. Yeah. It probably is one of that. The difference between the fit and the alkali denaturate. What's the other name for that, Leanne? The difference between fit and the fecal blood is that one is actually immunological and one is blood itself. So the fit one is the one they do for colon cancer, as opposed to just a plain fetal occult. I think it's the guaic acid, I think that's what it is. You all check that because they have apt is exactly the word that I'm trying to think of. What does the apt do? But you see, it doesn't matter because you answered stool DNA. Okay. y'all look that up. They do like this swallowing blood from sore nipples, and the question may go, what test would be the most appropriate for you to do next, right? So even though this was a red herring, and this was probably actually just a uric acid crystals, and it's benign, I have seen questions with swallowed blood and how do you diagnose it before. So make sure you have that one in your head. 37. 5-year-old is brought in by his parents because of daydreaming in school. You suspect that he may be having absence seizures. Of the following, the most appropriate features to support the diagnosis is yes. Okay, because usually it's more than 5 is complex, infrequent, that doesn't happen. Gradual, no, it comes on suddenly, right. Nicely eliminatable, precipitated by hypervitamin. 38. A 4-month-old is brought in to her GP because of constant crying and poor feeding. Fed by bottle on infant formula. Her mother tearfully complains that she's finding it very difficult to cope. She has a 20-month-old son who has recently been referred to speech and language therapists for language delay. The girl's development, growth, and physical examination are normal. What is the likely cause of this complaint? Yes, y'all didn't fall for it. Wow, that was a whole lot of fluff. Just that mommy is not coping. That was a lot of fluff and you didn't fall for it. All right. Because it started to set you up with the crying and the poor feeding like it might have been a cow's milk protein, but it's not. So good. This is the last one because I think number 40 was a repeat. 18-month-old girl is reviewed in the pediatric clinic. She's unsteady on her feet and walks with a limp and tends to fall. Her limb tone and reflexes are shown below. Right, so right arm and right leg, normal. Left arm and left leg, increased tone, increased reflexes. What is the most likely site of a neurological lesion? Right, so this is upper motor. How easy is this? And what is this type of cerebral palsy called? How would we classify it? Spastic hemiplegic, correct. So this would be spastic hemiplegic CP. And just because I like that, a spastic hemiplegic CP, how would you describe their gait? How do they walk? You said a limp, but there's something more classic that might have been in that. Yes, that circumducting gait. Because they hike over on one side so that they don't drag their foot and then they circumduct the other foot. Well done. And while I'm there, if it was spastic diplegic and it was both legs and the arms were normal, how would you describe that gait? A spastic diplegic, arms normal, legs have increased tone. What would that gait look like? Yes, they are scissor. Scissoring, yeah, they can have a scissoring gait. And what else do they do when they're walking? Tiptoe. Okay, let me tell you what word I want. The word I want was the crouching gait. Where you see the hips flex and the knees flex and they do scissor a little bit. One goes in front of the other and they look like they're crouching down and they walk like that. Okay. The diplegic, a spastic diplegic gait is a kind of crouching. It can be crouching and scissoring gait. Okay, that is it. So I will stop sharing and we will see what we're doing next. We will sort out that with Nirvana. I have the CVS and Abdul to go over with you. And I have the PowerPoint on common infections in Paeds.